lecture. Today's is sponsored by the Disparities Special Interest Group, and it's my privilege to introduce Dr. Brett Anderson. Dr. Anderson is the Florence Irving Associate Professor in the Division of Pediatric Cardiology at Columbia University. She is also Director of Outcomes and Quality for the Pediatric Heart Center and an NIH-funded health services researcher. Dr. Anderson completed an MD and an MBA at the University of Pennsylvania and a master's in patient-oriented research and biostatistics at Columbia. She completed her residency at the Children's Hospital of Philadelphia and a fellowship in pediatric cardiology at Columbia University. She is an invited member of the Society of Thoracic Surgeons Congenital Heart Surgery Database Task Force and the Task Force on Funded Research and the American Association of Thoracic Surgeons Congenital Quality Committee. She's using this background to do pioneering work to advance health equity and outcomes after pediatric heart surgery. Her R01 funded research focuses on the linkage and integration of large data sets and the application of econometric modeling to identify modifiable drivers of outcomes, value, and health inequities for children with congenital heart disease. Dr. Anderson, thank you so much for joining us today, and we're really looking forward to hearing about your important work.
Thank you so much for having me. I really appreciate it. All right, so a couple of us were talking at the beginning, and I was saying I am someone who typically likes to have a fairly interactive talk. That is harder over Zoom, but if people do have questions, really feel free to interrupt. And I might ask if actually at least a couple people can leave your cameras on. It helps me see that I'm actually explaining things in a reasonable way and get a little bit of feedback from your faces. Thank you. All right, so these are my disclosures. My other disclosure is that I'm someone who believes strongly in collaboration. So I believe in sharing data, sharing code, sharing your thought processes and your brain. And I think it not only allows us to do better work, but it allows it to be more fun and creative. And so I'm gonna talk a little bit about some of the work that we are doing in collaboration and where our thoughts are going from there. Okay, so for people who are not pediatric cardiologists, the first question is, why do we care about congenital heart disease and why is this an important thing to study? So congenital heart defects are the most common birth defects. They represent about 1% of live births. The CDC has stated they are the most expensive, at least in terms of acute care costs. We don't yet know much about long-term. And the long-term data on both outcomes and costs really are very limited. So long-term data, why is this a struggle? Well, the problem is, I just told you it's really a frequent condition, but they're very heterogeneous. So we have over 200 different procedures, over 200 different diagnoses. And so the power of single center studies is very limited. Multi-center data are often siloed in either procedure-based registries or the product of single investigations. Many have argued that administrative data lack clinical precision. We'll talk a little bit more about that later. And then the existing data on costs that exist have really focused on inpatient costs and use cost data that is based on cost to charge ratios, which for people who study costs, the problem with that is that if you standardize that, it may be a reflection of relative resources that are being used, but does not reflect the actual dollars that change hands. It's really more a measure of internal hospital cost accounting. Okay, so the American College of Cardiology, the American Heart Association, US Congress, and CDC all said longitudinal follow-up and understanding expenditures for congenital heart patients are top research and patient care priorities. Well, in addition, health inequities are real. So most of us sort of know that this is true no matter what field you are in. But it wasn't more than 5 years ago that people in pediatric cardiology and cardiac surgical space started to recognize this. and started to say, really, there are worse outcomes for minorities, from children from lower income neighborhoods, and for families who are on Medicaid. And I will say, so this is a study that we put out, now a bit dated, back in 2018. And we were focusing on thinking about the neighborhoods from which kids came. So quartile 1 is the lowest income neighborhood. And we wanted to think about the neighborhood after you control for race and ethnicity, insurance type, so arguably a measure of household income, and the hospitals at which patients receive their operations. And so we showed that there was an 18% increase in acute mortality. There was a 7% longer length of stay. And then if you flip that and said, well, what about after I control for the neighborhood and the payer, what's going on with race and what's going on with payer? So we found that Black non-Hispanic children had 23% higher mortality. Children on Medicaid had 15% higher mortality, and then 8% longer lengths of stay for Black non-Hispanic children, 11% longer for children on Medicaid. We're not the only ones to show this. So this is a great study that came out about a year and a half ago now, 2 years ago now, by Kayla Lopez and colleagues. If you can see my cursor, here is one. This would be what you would expect the mortality to be. This is the mortality for white children. And there was anywhere between 1.3 to 1.5 in risk ratio for children who were Black, and about 1.2 for kids who were Hispanic, as opposed to white children. Okay, so we know that there are disparities. To me, then the important question becomes, how do we think about intervening? How do we figure out how to fix this? And my real interest lies in moving beyond the description of these disparities and thinking about what is going on. So we've been spending a lot of time thinking about healthcare access and how do we investigate healthcare access. So our plan that we set out to accomplish was to first establish a population-based mechanism for longitudinal assessment. And we needed to define what long-term outcomes are. As we mentioned, we don't really know what goes on with these kids after they leave the hospital. And then we needed to define long-term expenditures and healthcare utilization. Where are they accessing care? And then our question is then to test different dimensions of healthcare access as modifiable mediators of health inequities. And ultimately, the goal would be to develop programs and policies to address these inequities. All right, so Medicaid data presents an opportunity. So one of the things that we know is that children on Medicaid, as we just said, are at higher risk of bad outcomes. We also know that about 50% of the children in the United States are on Medicaid, including about 50% of kids who undergo congenital heart surgery. The other thing that's important is that Medicaid for kids is a relatively stable form of insurance. So adults tend to churn on and off of Medicaid very frequently. Kids tend to go on Medicaid and stay on for a much longer period of time. Medicaid also not only has information on the inpatient stay, but it has information on all billed services for outpatient, emergency room, pharmacy, rehabilitation, home health. It's got data on early intervention and education services paid for by the state. It's got geolocation data and mother-infant pair data. So one can think about prenatal care, prenatal access, and long-term implications. And then it tracks patients across time and across institutions. So many of our longitudinal data rely on information that come from a single center. But as patients go back home and see their outpatient doctors, we often then don't have reliable information on what's happening to them. All right, so also for me presented an opportunity. So this woman is Sherry Gleed. She is the Dean of the NYU Wagner Graduate School of Public Service and one of the directors of the Health Evaluation and Analytics Laboratory there. She also happens to be a long-term mentor of mine. And NYU Wagner, a long time ago, partnered with the Department of Health, and they had Medicaid data that they had previously linked to housing subsidy data. They looked at gentrification. They looked at the effects on health of pretrial detention. Again, nothing to do with congenital heart disease here, but they looked at long-term health impacts of all of these different types of policies. And these data that they had, these were not the Medicaid max data. These came directly from the State Department of Health and had direct patient identifiers. So good, I can get access to this because she's my mentor, and I can then talk to the Department of Health. But I talked about these concerns about administrative data and our field having some skepticism about it and the level of clinical granularity that you can get from billing data. The problem is that national and state registry data present a lot of challenges. So accessing the Society of Thoracic Surgery data can cost upward of $100,000 per study that you do. And so if you really want to build a large, robust program to analyze these things, it can really be cost prohibitive. They also have their own data use agreements with the various centers who send them data that don't allow them to ship data out to you for your own use. Many states, so New York State has been involved in public reporting for congenital heart surgery back since the 1990s. And New York State really wanted to hand us all of their data, but the problem is that there's state legislation that says that they can't. And so figuring out how do we work around this? Well, what did we do? So we built the New York State Congenital Heart Surgery Collaborative for longitudinal outcomes and utilization of resources. What is this? So this is a collection of 10 of the 11 centers in New York State who have certificates of need to perform congenital heart surgery dating back to the early 2000s. And they all agreed to send to me all of their New York State and national clinical registry data. So every center owns their own data. And they then sent all of their historical data and now send to me twice a year all of their ongoing registry data. So in that data, these are data that are collected typically by former ICU nurses who become professional data abstractors, who don't pull billing codes. They manually look at charts, they manually look at operative reports, and they enter very detailed clinical information about what happens during patients' hospitalization. The problem with these data is that they end with the hospitalization or 30 days after 30 days after operation if the child is discharged before 30 days. And then we also brought in the Department of Health to partner with us with our long-term goal of thinking about how are we going to use any information we gather to actually implement policy changes. All right, so we took our clinical registry data that we have going back to the 1990s. We took our Medicaid data, which for us, it starts in 2006. We then brought in Census Bureau data and social programming data. So we've got social determinants of health and various social services. And we linked these data so that we could have granular clinical detail married with longitudinal follow-up. So we took an initial 14,000 eligible registry cases. And then we used a process of iterative, probabilistic, and deterministic matching. Ultimately, we had about 7,400 matches with an additional 2,000 partial matches. So these are kids that they were on Medicaid for some portion of time, but they didn't have an operative claim. And ultimately, we're able to match 67% of our total registry cases. Manual validation, we had nearly 100% true matches. And then there's questions of longitudinal follow-up. So as we think about this, and depending on what study we are using these data for, there are various criteria that we might use for how stringent we require their continuous Medicaid enrollment to be. But we've got about 80% 3-year data if we require near continuous enrollment, and about 60% or 65% at 10 years. All right, so what did we do next? So this is a mentee of mine, Phil Allen. He, when he was doing his medical degree, he also did a master's in science through our CTSA. And we talked a little bit earlier in this talk about the fact that people had raised concerns and questions about the granularity of our administrative data. So we set out to develop a new risk model that could be used within our administrative data for people who want to use administrative data to think about outcomes and resource utilization. So we used both our linked data from our CHS color, as well as a separate PHYS, so Pediatric Health Information System database, and 3 other hospitals, Society of Thoracic Surgeons, clinical registry data to develop the model and then validate it. So the story is, in the past risk models, we had a great model, our RACS-1 model. This was a consensus-based model. It was ICD-9 based. It has been used extensively, but in October of 2015, ICD-9 went away, and there was no good way to crosswalk ICD-9 to ICD-10 in our field. And so we had no new risk model to use since 2015. There's the STAT model. This is the Society of Thoracic Surgeons model. It is largely empirically based. It's a great model. The problem is that you can only use it in the clinical registry. So you can't use it in administrative data. And we already talked about some of the hurdles to using registry data. This is one of the reasons why people raise concerns about administrative data. So this study was published in 2013. It compared RACS-1 to the registry data. And what you see here is fairly poor sensitivity. So the RACS-1 model really did not capture nearly as many cases as the STAT model. There were also some significant differences that you see in the mortality that was predicted. And the other issue that came with this is that over time, the registry has added on, as our field has evolved, more and more different types of procedures that are included in their model that were just never included in the RACS-1. And then we talked about the transition to ICD-10. All right, so Phil set out to develop a new one. It started with RACS-1. We captured the procedures that were in RACS-1. Then he moved on to add in additional procedures until he got to the point where he included all of the procedures that were in the STAT model. And then he tested sensitivity and specificity of various ICD-10 coding and developed a model that explains greater than 80% of the variation in outcomes, which, as you see, is as good or better, I'd say as good as the STAT model, and greater than 99% sensitivity for case volumes. What I will say, and this is my first plug for collaboration, so we have made our code for this publicly available. Anyone who wants to use this, all you have to do is email me and I will send you a copy. We originally wrote it in Stata, and we are in the process of validating it in SAS as well. All right, so long-term outcomes. So this is Sarah Crook. So she is a biostatistician who works in my lab, and set out to first describe in our CHS color cohort, what does mortality look like over time? What are total Medicaid expenditures? So these are the actual dollars that change hands. And then to think about healthcare utilization. So where are patients accessing care? What does it look like early on and then over time? Look specifically at inpatient, primary care, subspecialist, and emergency room care. And then wanted to think about risk factors for different healthcare utilization. So we took our CHS cohort. We looked at all children in New York State who underwent initial cardiac operation in the linked cohort between 2006 and 2018, who had at least 1 year of Medicaid enrollment or who died postoperatively. And then we thought about various risk prediction possibilities. So we thought about the cardiac disease complexity, non-cardiac comorbidities and genetic syndromes, prematurity, race and ethnicity, sex, age at operation, surgical center, and year. So these are all data that are coming from the clinical registry. So they are not administrative coding based. For this, we use data that had been manually abstracted from charts by professional coders. And then we did some risk prediction. So we looked at mortality using Cox proportional hazard, expenditures using log linear models, and then healthcare utilization using Poisson. So in our data, there's some special considerations to think about. So one of the things is that our data is not a simple cross-sectional cohort. We have patients who received operations at various times. And we have some issues here. There's Medicaid enrollment. So there's some bias introduced. One is that patients' mortality, we have an issue that we can address fairly simply by censoring at disenrollment. But for expenditures and utilization, it becomes a little more complicated because you have patients who may disenroll non-randomly. Patients who disenroll may be more likely to be or are more likely to be lower income. And so this may also impact our outcomes. So the way we dealt with this was actually we just looked with and without the non-continuously enrolled patients. And then when we included the non-continuously enrolled patients, we corrected for the months enrolled. Survivor bias. So expenditures utilization are going to be impacted by survivor bias. So one, most of us who have studied this see that leading up to mortality, there is an increase in expenditures and resource utilization. And then once the patient dies, expenditures and utilization are arbitrarily truncated because they are not using healthcare resources thereafter. So we thought about this in two ways. One, we just modeled it with and without children who died. And then we also used something called Hexman selection models. So we looked at 1 year expenditures and utilization, and then we looked at expenditures and utilization after year one. And Heckman models allow us to think about what would have happened if we included patients who died prior to year one. And then our third consideration was thinking about the changing effects of risk factors over time. Longitudinal mortality, we then dealt with this, with and without operative mortality, and expenditures and utilization. We included patients subsequent to the initial hospitalization. All right, so mortality. We initially started this cohort with 5,200 kids who had at least 1 year enrollment. Among those kids, there was a 4.1% operative mortality. So again, for people who are not in cardiology field, we define operative mortality as anyone who dies in hospital or within the first 30 days if discharged prior to 30 days. Of those, then, we sort of restricted our population, as we said, to think about what about just the 5-year continuously enrolled cohort. So for those kids, you had to have been born between 2006 and 2014. We had about 2,000 kids who were continuously enrolled. Our 5-year mortality for those kids was about 14%. All right, total expenditures. So we looked by year, and for kids, if you include the initial hospitalization, we're talking about $140,000 in year one, about $58,000 of spending if you exclude that initial hospitalization, with still the bulk of spending after initial hospitalization being inpatient. This is in contrast, you see down here, about 6.7 thousand for non-cardiac surgical patient controls in the Medicaid population. And then out at year 5, talking about $18,000 per patient per year, as opposed to about $4,000 for the non-cardiac surgical population. We said about 58% in year 1, after you exclude the initial hospitalization, were inpatient related charge or inpatient related expenditures. In year 2, you're talking about 33% and about 30% again out at year 5. Next major contribution was chronic care, followed by education, prescriptions, outpatient care, and what you see there, that light pink is actually a very small sliver was related to emergency care. All right, so let's talk about these inpatient admissions. What was going on? So the way these next couple slides are divided up, the blue line talks about the average expenditures in cardiac kids in the first year. The green is the 3-year average. The red is the 5-year average. And then that black line on the bottom is the 1-year average for non-cardiac surgical Medicaid matched patients. What we see is that on average, in year 1, cardiac surgical patients are admitted twice for a total of about 31 inpatient days, versus non-cardiac patients who are admitted about 0.3, so largely birth admissions for an average of 2 inpatient days. ER visits, really frankly, are not all that different. Maybe a little bit higher in year 1, and certainly we've got data where we stratify by cardiac disease type, and our single ventricle patients layer much higher than the rest of our population, but our ER visits are not dramatically different from the rest of the Medicaid population. Primary care visits, on the other hand, are very different. So in year 1, our cardiac surgical patients are expected to have about 11 primary care visits versus about 6.7 for non-cardiac surgical comparators. And our cardiac kids are expected to have about 5 primary care visits per year, 5 years out from operation, versus about 3.5 for non-cardiac surgical patients. How about subspecialist visits? One of the things really interesting, if you look here along the bottom axis, so we're going across time, and that, for our 1, 3, and 5 year, they're all going up fairly dramatically across time among our cardiac patients. With our cardiac kids in year 1, seeing subspecialists about 6 times per year versus non-cardiac kids who see fewer than 1 subspecialist in year 1. Okay, let's talk a little bit about predictors of mortality and expenditures and utilization. And for purposes of this talk, we really focused, I'm going to just talk about race and ethnicity as a primary focus. So as we looked at predictors of mortality, we found sort of fairly similar results to what's been shown previously. We do a lot of different sensitivity analyses, and depending on exactly which sensitivity analysis and how we do our population, our confidence intervals vary. But in general, we see somewhere about a 20 to 30% increase in mortality among Black and Hispanic children early on, and a similar 30 to 50% increase in mortality by 5 years of age. And how about healthcare utilization? Well, interestingly, these top lines, expenditures are not really all that different. So let me just orient you to these graphs. So the first thing we have here is our 1-year models. And then second, we have our 2 to 5 year models. Across the top, we have our expenditures. And then we have sort of various measures of ways in which kids are accessing care. So you see in 1 year, looks pretty identical. In our 2 to 5 year, it's possible that our non-Hispanic Black children have slightly lower expenditures than our non-Hispanic white. Our admissions are relatively similar. Our total number of days that they're admitted may be a little higher in the 2 to 5 year period. But what's really striking is our primary care visits. So our Hispanic and non-Hispanic Black kids are seeing primary care doctors 20 to 50% less than our non-Hispanic white kids on Medicaid. And our emergency room visits, in contrast, are dramatically higher. So our Hispanic and our non-Hispanic Black patients are seeing, and depending on, which end of the confidence interval you want to look at, somewhere from, 10 to 60% more emergency room visits, not just in the first year, but all the way out through year 5 than our non-Hispanic white children. Okay, why? Right? So now we say this is happening. We at least now started to look a little bit about ways in which these kids are accessing, using care a little bit differently. And so the next question is to think about what's going on with access. And is this really driving outcomes, or is this a reasonable descriptor that maybe is the result of differences in place or where kids live? All right, so I like to think about this stuff across time. So one of the first steps is thinking about what's going on in the prenatal space. So this is a mentee of mine. She's a fetal cardiologist, Joyce Wu. She's now up at Northwestern, and she's really interested in thinking about prenatal screening. So she took our CHS color data. She took all infants who underwent cardiac surgery in the first 60 days of life, 2006 to 2018. And she looked for children with the same family Medicaid ID, for women who were between the ages of 15 and 45 who were continuously enrolled in Medicaid. And she performed similar matching algorithms and focused on linking then on infant date of birth and OB delivery claim date. Developed a matched cohort of 1,500 kids with an 88% match rate. Among these kids, she found that about 17% had a level 2 ultrasound only, 12% had a fetal echo only, about half had both, but you're looking at nearly a quarter of these kids had neither. So now the question becomes, and this is the bugaboo for everyone who's interested in thinking about, I just said bugaboo, but it's the issue for anyone interested in thinking about prenatal screening as a predictor of outcomes. Becomes a little challenging to now look at. The question is, what is it really having an effect? All of us clinically think that kids do better when we know about it prenatally and we are able to plan for it. So the question for her on her next steps, and she's in the process of submitting a career development award to think about, what are the implications on timing and total prenatal care visits? Is it really the fetal echo? Is that the issue? Do we really care about the prenatal cardiologist, or is it just prenatal care at large? Is it in fact the fetal echo? Maybe level 2 ultrasounds are good enough. And is it a fetal echo, or is it a fetal echo at a cardiac center? And then next step is going to be to then see which of these things predict birth at a cardiac center and ultimately outcomes for the baby. All right, okay, so we're thinking about prenatal care. What about what happens when the kid's born? What about what happens at surgery? So our next steps We talked about birth at a cardiac center already. The next step is for us to dig a little bit deeper to think about timing of postnatal cardiac evaluation and surgery, and in the context of the distance to the utilized providers and the distance to the nearest provider, and then thinking about median surgical timing. And then we get back to this question of, okay, they're operated on. Now what is going on in their primary care versus their emergency room utilization, and what's happening with these kids long term. So a couple of questions that we have in our head to really understand. Is there maybe sort of rational switching between what care is being utilized where? And so are there really differences in primary preventative visits, or is it urgent care visits that are being shunted to either the primary care versus the emergency room? So our next step is really going to be to dig a little bit deeper, to think about the percentage of well-child visits that are timely completed, the percentage of vaccinations that are timely completed as markers of, are these kids getting adequate, true preventative primary care? And then we want to think about relative distances to the care that they are utilizing. And then think about what care they are getting is actually within a pediatric or cardiac care center versus in a care center that does not have access to pediatricians or to pediatric cardiologists. So for people who think about this, one of the questions, and particularly as we think about New York State, may be that there may be significant urban-rural differences in the ways in which kids access care that are very rational, that may explain some of our observed differences in race on care utilization. So what do I mean by that? Well, if you live in Washington Heights, where Columbia is located, your primary care doctor might be a city health center where you see a different primary care doctor every time you go. But if you come into the emergency room, you get your primary cardiology team to see you every time you come in. If, however, you live in a rural part of New York, your emergency care might be at an adult ER that does not fully have the same appreciation for pediatric care at large. But your primary care doctor might be your local doctor who sees you every time you come in and gives you great continuity of care and knows everything there is to know about your cardiac disease. So as we think through these questions of who's accessing care where, and as much as I would love to say, look, we found this really significant thing, primary care is so different from emergency care across races within our state for our population. What we're going to have to do next, and where we think we're going, is to dig a little bit deeper about what are the types of care within these different centers that patients are accessing, and is this true rational division of care access, or is this problematic? All right, with that, I'm going to pause and open it up for questions.